So we're ready to start. Thank you all so much to our wonderful in-person turnout and those of you online. It is my pleasure today to welcome Dr. Despina Kontos, who is the Matthew J. Wilson Professor of Research Radiology and Associate Vice Chair for Research at the Radiology Department of the University of Pennsylvania. Dr. Kontos received her civil engineering diploma in computer engineering and informatics from the University of Patras in Greece, and her master's and PhD degrees in computer science from Temple University in Philadelphia. She completed her postdoctoral training in radiologic physics and biostatistics at the University of Pennsylvania, and additional postgraduate training in the cancer molecular biology and in therapeutics from Harvard Medical School. Dr. Kontos' research interests lie in the interface of engineering, data science, and medical imaging applications. Most of her research to date has focused on leveraging the role of machine learning and AI in investigating the role of imaging as a predictive biomarker for guiding precision cancer screening, prognosis, and treatment, while integrating with other emerging multi-omic biomarkers, such as molecular profiling, liquid biopsy, and the EHR. She has published more than 100 papers in this field, leading several research studies, and is funded by the NIH and NCI and private foundations. So we're so delighted to have you here with us. She has expressed that she is open for questions, and so I think we can hear things. So folks online, if you have questions, feel free to raise your hands. I'll sort of monitor and try to get her attention, and same for in person. And without further ado.
Thank you. Thank you so much for the wonderful introduction. Thank you. And the very warm welcome. The one thing that wasn't added in the introduction is that I'm joining you guys starting January 1st. So January 1st, I'm joining Columbia University, and I would be very excited I'm very excited to become part of this community. I've been in Philadelphia and I've been for many years. It's been a wonderful journey. I'm also a little tired tonight, not just because I took a 6:30 a.m. train from Philly, but because the Phillies won 10-0 last night. It was a late game. So, and that's a total humiliating for the other side. So we're excited, looking forward to Thursday for the next game. It's like 10-0. Can you believe that? Without even Taylor Swift in the, so yeah, that's another major thing in the news these days. Okay, so what do we do in my lab? So the lab will also be moving here as well, and it will be great to be part of the very engaging community that you guys have here in the department. So primarily my background is in computer science and engineering with a little bit of flavor of biostatistics, epidemiology, and cancer biology along the way in my postgraduate journey. And so a lot of the work that we do focuses on developing image analysis techniques, pattern recognition, data mining methods to investigate the role of imaging as a biomarker for personalized clinical decisions in cancer care. Most of my work so far has been in breast cancer and lung cancer, and that's where I'm going to throw some examples. We're actively kind of branching out to other areas as well, and the methods I'll describe here are generically applicable to this type of data. So when we think about cancer, I'd like to think it in three main ways: screening and prevention, presumably a symptomatic population; prognosis, once you have a disease, are you going to recur? Do you need aggressive therapy and so forth? And treatment, once you're under treatment, are you responding in that therapy? Do you need a different therapy? What's the risk-benefit ratio there? And a lot of the work what we do is not necessarily in diagnosing, not so much where's the cancer, is this a cancer kind of question, but more into the predictive modeling. So what will happen in the future? Are you going to get this disease? Are you going to recur? Are you going to respond to this therapy? And those type of questions. And in my view, imaging data is probably one of the most untapped resources of biomarker information that we have in a healthcare system. If you think about it, a scan is being done primarily for like detection or some diagnosis. The radiologist literally reads it probably for less than a minute. Then a report is generated, and then everybody after that primarily sees that report. And you have this high dimensional data, through 2D data, 3D data, 4D data, really expensive to acquire, that are also done routinely, clinically. They're then just sitting in a database forever, and nobody else takes another look ever again. But at the same time, they visualize the entire anatomy, and especially for cancer, and I'll talk a little bit more about that, is probably the only modality that can give you an in vivo characterization of tumor heterogeneity and a lot of the properties that we know are important for developing resistance to therapy and so forth. So a lot of the work I've been doing in this field started with working in the area of predicting the risk to develop breast cancer. So, I'm a symptomatic woman walking into the clinic the day my annual mammogram. what's the risk of developing breast cancer? And why is that important at the end of the day, right? Because it helps us personalize the screening protocol. How often do you need to be screened? With what modality? For some very high-risk women, we can have risk-reducing interventions. But as always, we have to, the trade-off, the risk and benefit ratio. So some of the work we've done in this field is basically take a lot of pattern sort of analysis techniques to try and characterize the pattern of the presumably healthy tissue, because it's been shown for many, many years of research that the complexity of the breast tissue, what we call breast density, is a major risk factor for breast cancer. And this field really started more than 30 years ago when a scientist at the time called John Wolfe visually was observing this type of images that were called zero mammography at the time, and he could visually appreciate that there was something about the complexity of the parenchymal structure in which women were likely to be diagnosed with breast cancer. And a lot of his peers thought that he was like talking nonsense and nobody believed him, but like 30 years later, we now know that what we call mammographic density, and you may have heard a lot about it because it's in the news often, because there's even legislation to measure it and report it to women that undergo screening mammography. Breast density is an important factor to be measured because it increases the risk of breast cancer, both by giving an inherently higher likelihood for new cancer cells to develop and get the disease, but also it can mask the presence of cancer in the image. And so a cancer may be hiding under dense tissue, the mammogram may not detect it, and then you get detected later when the cancer is advanced or metastasized, which is much more difficult to treat. So what we and others in the field have done is, first of all, to develop fully automated methods to measure this breast density from multimodality breast imaging data, from two-dimensional mammograms. Now we have three-dimensional digital breast tomosynthesis scans. We have three-dimensional breast MRIs. So let's get beyond the qualitative visual evaluation that's done clinically, that's very subjective, and get quantitative reproducible methods. And a lot of these methods are publicly available. You can download them, you can use them in your research and so forth. But going back to what Wolfe was looking at originally, and you can see an example of that still here in the modern images, you may have images, for example, as those in the left-hand side that are considered to have like high density. But if you look at the pattern, there's definitely different pattern in the image. The one's more spread out, a little bit more patchy. The other one is more clumped and more homogeneous. But at the same time, there's some, if you see that breasts are supposed to have low density and be at a low risk to develop the disease, you can still see that there is a pattern. So going back to what Wolfe was observing, the question we and others have posed is this sort of breast density binary measure, which is basically the bright stuff in the image versus the dark stuff in the image, enough to capture that notion of complexity? So this is the field, in medical image analysis, the past 10 years or so has seen an explosion of this research around radiomics. And if you ask me what radiomics is, I often say that that's when radiology got jealous that they also had to have something that ends in omics to be able to be, fundable. But really, these features were invented and were starting to use in the 70s. Before even John Wolfe. In fact, in military applications at the time and satellite imaging and those type of things. And then those features ended up finding their place in other applications and more recently medical imaging. So what do we mean by the extraction and analysis of large amounts of advanced quantitative imaging features with high throughput from medical images? Maybe a lot of you are more familiar with RNA sequencing and other types of high throughput data extraction. If we start thinking of imaging data in a similar way, that imaging is not just a diagnostic modality, but it's an assay. We have an organ, the tissue, that interacts with X-rays or with protons or with magnets or whatever, or with ultrasound, and the tissue reacts to that, and it generates an output that is captured by a detector. Then you can think about it in a similar way as you would analyze tissue in other ways, and then you can use computational methods to extract features that can capture all kinds of information. So morphology, like size of tumors, circularity, irregularity, the sharpness of the margins that we know is related to infiltration and likelihood of recurrence. If you have, let's say, dynamic imaging modalities like MRI with a contrast agent, you can capture the kinetics, which have to do with angiogenesis. You have PET, those measurements have to do with how the tracer binds to different targets. You can capture textual patterns and characteristics. You can capture high order statistics. I don't know how many of you have a signal processing background like Fourier transformation type of measurements, wavelets, fractal dimensions, and all kinds of things. So as you can imagine, there are hundreds, there are thousands of features that can be extracted. from an informatician sort of perspective, a lot of redundant information potentially. How do we deal with those features? How do we parameterize them? How do we include them in modeling and things like that are very active questions. So a way to do this, for example, in a mammographic image is we can sample the breast at different resolutions. We can do it in a way that can cover the entire. We can go as close to pixel resolution or as coarse as the whole image resolution. You know, obviously, if you go too fine, you're capturing a lot of noise. If you go too coarse, you're going back to something like density. So there's like a sweet spot where you get the best of both worlds. And again, I won't bore you with that because you probably know a lot of this, you know, type of measurements already. You know, you can extract simple features from the histogram distribution of the gray level values, like skewness. And how does that interpret? For example, a dense region of interest in a mammogram, like density, tends to have negative skewness. A fatty area in a mammogram tends to have positive skewness. Coarseness, which is a measurement of local variation in image intensity, and can give us quantitative measurements on a finer texture versus coarser texture. Sometimes the slides have a bit of a Mac allergy, so it's all good. I'm more of a Windows person. No problem with Macs. I just never cross paths, so it's all good. Other features that basically quantify the relationship of gray level values, like how often gray level values that are very different appear next to each other versus gray level values that are similar to each other appear next to each other. So for example, you can see a high contrast. There's also low contrast there, but the Mac doesn't like it. And then fractal dimension, which is extracting information about self-similarity patterns at different resolutions, which often are represented into natural structures. So a tissue that may be starting to show signs of developing a malignancy or early malignancy might start distorting that natural pattern of a natural fractal dimension, for example. Yes.
So we had this study that we did where we were looking at chest x-rays. We had Columbia chest x-rays and Stanford chest x-rays. And we applied like a pre-processing framework, and pre-processing framework was really similar. And then we watched like one of our models performance drop a lot at Stanford. And then I asked Shreyas, the PhD students working there, hey, could you just take 100 chest x-rays? Half of them are from Columbia, half of them from Stanford. And let me see if I can tell the difference between them. And I couldn't. It batted 50%. But then, you know, an AI model could tell with 100% accuracy. So these sorts of things of like that you just described and the quantitation aspect, they're so valuable. Are there real limitations like, hey, this person is using this vendor and like what they call their blackest black is different than these people, or they're using contrast limited adaptive histogram equalization or whatever? Well, I don't know. Is that something, because radiology, I do think, is way ahead of a lot of other fields in trying to keep a lot of things in the metadata and trying to make it clear. But I don't know if that's a real challenge of the reproducibility of this stuff, or is it just a solved problem?
It's an excellent question. We probably could give a whole another talk on this topic. A lot of PhD pieces done on this, and I have a few slides, but it's a challenge, but in my view, it's also an opportunity. You know, if you want to develop real world data, models that work and are reproducible, you can develop them in ultra sanitized data sets that have no noise and everything's super harmonized. You know, that's not going to work either. Right? There are some simple sort of image harmonization techniques that standardize the image itself. But as you said, there are differences in the acquisition protocol that are usually captured by in the DICOM header as different dose levels, different reconstructions, different. So in this field in radiomics, our groups and others have borrowed statistical techniques that are used, let's say, in RNA sequencing and other fields in genetics, like COMBAT, for example, and develop statistical methods that can harmonize in the post-processing setting, not the scans. I'm not as big a fan. I mean, it's good to have some common, you know, standards for the scans, but you will never, ever, ever be able to fully harmonize all the scans. There have been groups in this field that have been trying to do that since I was a grad student, still not happening, because by the time you try to harmonize the one scanner, then Siemens comes out with the other scanner, and then you try to do that, and the other, it's not happening. So it's good to have some common rules, but there's heterogeneity, and that's not going to change. So I'm a big fan of post-processing techniques, take the features and work on harmonizing the features. And then you can look in the DICOM headers and take up what we call batch effects, like, let's say, field of view, resolution, blah, 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 blah. And we have developed, for example, some algorithms that are publicly available that go into the process of like, how do you optimize the harmonization? Like if you have a bunch of acquisition effects, you can harmonize simultaneously, you can do it sequentially, you can do it in conjunction with your outcome. So how can I harmonize so the best predict the outcome. How can I harmonize by protecting certain variables? You don't want to let's say if there was any association with like some of your demographic characteristics, you want to protect that. You don't want to wipe that out in harmonization. So there are tools to deal with that. But at the end of the day, I think a little noise in the data is probably not a bad thing. It helps, the radiologists read with the same accuracy all the scanners. We throw them a Siemens of this and that, all good, right? So if the human neural network can do it, maybe we can push the artificial one to get a little closer to that, which I think is doable. And then when we extract these measurements, so for example, I'll ask a question. Where have most of you seen a heat map like this before? Like this pops up, what comes to your mind first thing? Yes. Exactly. But we can do the same things with also these measurements, right? You extract the measurements, so basically you have an assay, a signature. So here, every column represents a scan, and every row represents a measurement of those radiomic features. So I guess it wasn't too bad that radiology took that omic on, because it can be treated in a similar way. And then you apply similar techniques, like unsupervised hierarchical clustering, for example, or other techniques to try to identify intrinsic phenotypes, imaging phenotypes. So tissue that looks a similar way, tumors that look a similar way or appear in a similar way. And if you think about it, there could be a lot of complementarity, right? Something like, what you just mentioned gives you an idea, of the blueprint, of the transcription, even epigenetics and all that stuff. But this is the end product in some way, right? All these other genetic factors contributed to, at the end of the day, develop this. So you kind of have pieces of both, both aspects of this process that can have complementary information. And here, when we look at the signature as compared to conventional density in this example, we see that there's definitely complementary information. Like there are breasts that may be very dense, but not very complex, like all dense, right? All like smooth dense, but they can be breasts that can be low density, but still have high complexity. So then the question is, at the end, and you can see an example here, we can quantify that complexity now with a complexity score. So what these features also help you do, it was funny because when we looked at that graph, the first thing that came up, there were 4 phenotypes. Remember Wolf, 4 phenotypes. He also had 4 groups. And I say, the first thing I say is like, it'll be so fun if we do all this fancy stuff to go back to what Wolf was looking at 40 years ago, right? But maybe that's the nature of the data, right? But the thing that this allows us to do is to give it a number and go from a qualitative assessment to a number that's reproducible. You run it 100 times, you're going to get the same number, and you can rank everybody, and you can have a better assessment of high risk, low risk, and so forth. You can use those numbers to build models. So the first sort of exploratory evaluation we did was a small case control study. We took women who had cancer and women who did not, and we took the unaffected breast at the time of diagnosis for the ones who did have cancer, with the premise, if there were some intrinsic properties of the tissue that were predisposing you, then the unaffected breast shows that intrinsic sort of pattern. And then we looked at, basically just the classifiers to see, if we can see an association with a phenotype category to the outcome when you adjust for density and other known factors like BMI, ethnicity, age, and things like that. And these preliminary evaluations, we started seeing in the small data sets that this was indeed the case, and we could see, significant added value. This motivated then a larger consortium study, a larger NIH sort of grant between Penn, Mayo Clinic, and UCSF, where we basically went from a few hundred cases to 35,000 women. And we took screening data, mammograms from 35,000 women. We tried to see if this notion of the phenotyping replicates. We split an independent validation. This data were presented last year at the San Antonio Breast Cancer Symposium as an oral presentation, which is kind of rare in an oncology conference if you've ever been to one. And we're about to submit the publication this week to a journal as well. So what we saw is we could replicate the notion of phenotyping in the larger sample, obviously much smaller p-values because you have a much larger sample. And then we also saw that once you, again, then we took an independent case control sample than the one that we developed the phenotypes with more than 1,000 cases and matched controls, and try to see associations again with breast cancer, but this time, not the unaffected breast at the time of diagnosis, truly the priors, a year or more earlier, to see if we could predict which women were going to develop breast cancer. And again, we saw predictive value and adding value to some of the conventional factors of the clinically assessed density and age and demographics, especially in the case So when you detect a cancer, always the question, is it like, was it missed? Is it what we call like a false negative or a masked cancer, or is it truly new incident? And we saw that we could see this benefit particularly in the area of like missed cancers. So where the breast was so complex that the radiologist couldn't see the cancer in the beginning. So this could have a good value. There's a lot of discussion right now about supplemental screening based on breast density. And actually there's federal law that mandates that when you get a mammogram, the doctor should tell you what's your breast density. And then if you have the breast density, they should refer you ideally or at least have a discussion about what else you can do, like supplemental screening. And you can get MRI or ultrasound and so forth. So this could be something that could help further narrow down the number of women who really need those additional procedures and imaging. Because if you go by the clinical assessment of breast density, half of the US population is under moderately to highly dense, so they would qualify. To give you a sense of the yield, mammographic screening detection for breast cancer is 5 per 1,000. When you add supplemental screening, it gets 10, 15 in really, really high BRCA carriers, something like that. So it would be a lot of additional procedures to do half to the US women population to find those fewer cancers if we were just going by clinical assessment. But if you have something quantitative that you can help you stratify and make that funnel, much, much more specific, then we can really have more effective screening strategies. And this is an area that we're very, very actively working on and trying to build and add also AI components in this prediction and so forth. I have nothing against AI. I love AI, but this was just some work on radiomics. Yes.
So I had a question. So
yes, sure.
That, obviously, these are the radiomic features.
Yes.
You try to use like the raw image.
Like a resonant type of, we're working on that. So here's the tricky part, especially when you go through 3D mammography, it is hard, really hard to train those networks. Like they take days and days and days to converge, even in very strong, powerful clusters, right? And so actually we're doing that analysis right now. We're trying to compare what's the value of taking like the raw scans versus taking just the features and doing a more conventional radiomic analysis, putting the radiomics into a deep learning approach and maybe using like a vision transformer or something like that to add the clinical data. At the end, there has to be, it's great to do all that stuff to satisfy academic curiosity, right? If you can get decent performance with a simpler approach, I'm all for it. That's probably going to make a better model. So on that, the jury is still out. But as I said, these methods are very agnostic at the end of the day in terms of what imaging data you're feeding into them. And so, for example, we took some of these methods that were applied originally in breast cancer and we adapted them to 3-dimensional CT data. And we started looking at the patterns of the lung parenchyma and how does that relate with the likelihood to develop lung cancer. That's another area that, lung cancer screening is where breast cancer screening used to be like 20 years ago. I mean, there's like slow adaptation. A lot of places are doing it. The criteria are very coarse. Basically, you have to be a very, very heavy smoker to qualify. And we know that lung cancer doesn't just show up in very, very heavy smokers. It can show up in people who don't smoke at all. And so how do we better identify that population and how do we risk stratify is a question that is still very, very open as compared to like breast cancer. And how do we enhance compliance or like risk reducing interventions such as smoking cessation? And so, again, we're starting playing with the same idea of using these techniques, adapting them to 3D data, phenotyping the lung parenchyma, and doing some, in this setting, still some feasibility studies just to see that, for example, again, we can uncover phenotypes. We try to see how robust they are, for example, across like different kernels in the reconstruction, how we can, and if we start seeing some associations in very small samples with the likelihood of developing cancer, which we were able to see in a small sample. This is just feasibility kind of study to show that there's maybe something in here worth investigating further. Yes.
I'm just kind of curious. So for the lung cancer one, you have a similar set of parameters like which were defined in breast cancer detection, like the complexity and density.
Yes. We have the complexity, which is you see a little bit here, like the lungs at the color-coded texturals. But you can also have measures like emphysema that's basically thresholding the scan at a certain gray level value that represents Hounsfield units. It's kind of a very similar notion to the density where you get the mammogram and you threshold it to get the bright stuff versus the dark stuff. You do the same in the CTs, and you get a sense of their COPD and to which extent, and so forth, which is also a risk factor for lung cancer. So in my mind, those things were very similar. Breast density, risk factor for breast cancer. COPD, risk factor for lung cancer.
So what is the challenge for risk stratification in lung?
It's just not broadly available. First of all, they're not many, I think, well-established high-volume lung cancer screening programs. I mean, at Penn, for example, we have lung cancer screening, things since, 20 to 15 years ago or something, right? We see a volume of like 12,000 women just in the main hospital, not all the other hospitals, of 12,000. If you go across the board, you probably get like 20, 30,000 women a year. Lung cancer, the program is maybe like 5 years old and sees 1,000 a year. It's hard to get access to that population and convince them to come in for a CT, right? And also, who's high risk? I mean, yes, the very, very heavy smokers, that's basically the only current criteria. But should the rest of us not ever consider lung cancer screening? I don't know. And lung cancer, to be honest, is much more lethal than breast cancer in the majority. Like with breast cancer is very easy, first of all, to biopsy. You get a biopsy in the breast. Yes, it's uncomfortable. It's not the best thing that can happen to you, but it's not gonna, it's fine. You don't even need whole body anesthesia or anything like that. When you do a lung cancer biopsy, though, the biopsy itself can kill the patient because the lung may collapse, and it's a dangerous procedure. So we can't just go around doing it. In the breast, if you have a delegacy, it's still bad, right? In the lung, you won't do that. So that's even more important there to have good risk stratification measures, because you do have false positives that come up. And so how do you deal with those? And building that risk profile, I think, still needs a lot of work. Yes.
Do you use persistent homology to derive the fractal dimension, or either of those things used in the phenotyping?
Yes, fractal dimension type features, wavelength transformations, Fourier, all those kind of higher kind of self-similarity pattern type of measures. Yes.
And it might be too methodological, but is that how the curve shape index in your slide on the kinetic variables is calculated?
It could be calculated that way as well, but you also can calculate it. You can calculate the slope from a fractal dimension type of thing, but you can also just calculate the wash in and wash out of the kinetic curve as well, which is more simple. Right. Excellent questions. And then we get a little bit into what we were just talking about, the harmonization of these features. And in life, I think, is general, it's best to be realistic and deal with reality than pretend that reality is not reality. There's heterogeneity in the scans, period. And that will always exist. We will never get rid of that. And so the best way to think about it is how can we deal with it effectively, right? And so there's statistical methods that have been developed. A group, especially recently, has published a bunch of those methods, all available in GitHub for accessing, based on enhancing combat, either with sequential harmonization or simultaneous harmonization, or in conjunction with the outcome, and so forth. And this is actually, if you're interested in those kinds of statistics, this is some work we would love to continue to do here, and have students who can work on that in conjunction with the biostatistics department and kind of build on that in these methods. And of course, there's deep learning. Of course, the not so much elephant anymore in the room. Great approaches, it would be, the computation is a challenge when you have, let's say, 100,000 digital breast tomosynthesis scans, that each of them is the equivalent of 100 mammograms, and you have 2 views and, 2 breasts and 2 views, very heavy data. I can't even tell you how many times we get cluster notifications that one of my students is crashing the entire thing, basically. And if they don't stop, they're gonna terminate us and things like that. That's a very frequent phenomenon when we try to train those networks. But I also don't see it as a competitive approach necessarily with radiomics versus deep learning. There could definitely be a way that we can use some prior knowledge, extract some features, reduce the computational complexity that way. And then, yes, by all means, use deep learning to synthesize those features and try to mine more information out of the data. And we did an early study that showed that there may be an appreciable performance improvement if we sort of combine the best of both worlds. If you think about it, a CNN basically what it does in vision is multi-resolution type of filters, kind of textual feature extraction. So it's basically radiomics on steroids. You just don't see it. It's all done in the networks. You have the convolutions, you have the aggregation, and it gives you the outcome. And of course, it's great to have some interpretation of these models. I'm very excited about aspects of interpretable AI, not just because the clinicians will trust them more and all that, that's also good, but I think it also can shed some insight to biological interpretation. So what are the parts of the breast that drive breast cancer, right? Is there the glandular tissue that we believe for so long? Maybe it's the fat, because the fat is responsible more for the production of hormones that may be driving, breast cancer. Maybe it, other anatomies. The same thing for the lung. Like what areas of the lung are those ultimately, and how does the model? What is the model that the model sees that we can't see and predicts the future? That is something I'm very excited about. And then we can go to the bench and go to the biology scientists and say, hey, this is what the model is showing. Is there any value to this? Let's make some animal models, see if that is the case. Maybe we can even come up with a risk reducing strategy. If we can find a biological pathway, a new pathway that we didn't know that increases risk. It's funny, there's been 30 years of breast density research, and we still don't understand why breast density adds to the risk of breast cancer. We know that it holds observationally, but the mystery is not fully resolved in terms of biology. You can think again in a similar way that I talked about the whole breast pattern, about characterizing patterns of tumors and using that information to predict future outcomes of patients, responses to certain therapies, likelihood of recurrence. And here this is an area also that radiology in the field came up, like radiogenomics, another omics, where we can combine information from like imaging, which is the phenotype, the end product, very, very useful in characterizing heterogeneity, and molecular profiling assays, and other factors, and digital pathology, histology, and put all that information to predict outcomes. And similar, breast density being a risk factor, there are also kind of nomograms that the oncologists use in the clinic to try to make these clinical decisions. There's always a risk to benefit question, like if I give this therapy, what are the minuses, what are the benefits, and try to weigh those in when making decisions, for example, for a treatment. In this arena, it used to be just conventional histopathology type of characteristics, but now we also have a lot of molecular profiling assays that have emerged. For example, Oncotype DX, it's a proprietary assay based on 21 genes that are profiled. It's used pretty much in all breast cancer at this point, certainly primary invasive, ductal carcinoma in situ. I think now it's also for a different type of receptor. So it's used very broadly. It's done pretty much in every woman diagnosed with these types of cancers in the beginning. It costs $4,000 per assay. I think that's how much it used to cost about, several years ago. And it goes to a certain lab in California and then comes back. There's a reason why I'm saying this information, but basically based on this assay, if it gives a score as to how likely you are based on the genetics of the tumor to get a recurrence, and then the oncologists decide if you're going to get just endocrine therapy, which has the least side effects, or also adjuvant chemotherapy, which it's more of a systemic therapy with more toxic side effects. A very important decision. But one of the things that we're now increasingly appreciating is that tumors are very heterogeneous, not across individuals, but also within the same tumor. So think about how we make all these decisions about all these assays, which is great, is using very, very small tissue samples. So for example, if you sample the purple type part of the tumor, you may get XY information about the genetic makeup or the receptors or whatever. If you target the other part of the tumor, maybe if you sample the other one, it could have been different. So you're making your decision on what to target based on the teeny tiny tissue sample that you had. Some part of the tumor responds, the rest of the tumor takes an opportunity to develop resistance, right? And that's how a lot of the therapies fail. So the phenomenon of tumor heterogeneity is very important, and there's a critical need to better capture that clinically. That's what liquid biopsy sort of came to be, to try to get some of that, circulating marker data that can probably give us more information about the tumor than a single biopsy. But if you think about it, imaging is probably the only assay, at least visually, shows you the entire thing in vivo, non-invasively. It's done routinely, doesn't cost extra because it's done anyways, and nobody looks at it. Right? So if we had a way to decode that phenotype into a biologically sort of meaningful signature, we could literally have virtual biopsies that could tell us about the whole tumor, not just a little tissue. This is an area I'm very excited about, and especially making the link from the radiomics or the AI, however you want to call it, back to the biology and what those signatures mean, because I think it would offer a lot of information for therapy. So again, an important component here is like, segmentation methods, like tons in the field. How do you automate the delineation of the tumor? How do you make it accurate? Very important step in the pipeline of the radiomic analysis. And then on top of that, for example, when you have dynamic data, you can get some functional information in addition to some of the textual type of measurements that I talked previously. So here, for example, you see a breast MRI scan. I don't know if you know how about breast MRI is acquired. You go into the tube, you get a first scan before the injection of the contrast agent. Then after a little bit, there's a little beep, and the contrast agent gets into your veins, and then they take scans, longitudinally for a few minutes or a second, and so forth. And then you can see how the contrast agent was taken up in the image, the background of the breast, but also the tumor. And why, does anybody know why is it that the tumors light up in the image when you do that? Exactly, right? They have angiogenesis. So they take up more contrast agent, they tend to light up quickly, but they also tend to lose the contrast agent quickly. So that's why the washing slopes and the washout slopes are important. Fast washing, tumor, slow washing, background. Fast washout, tumor, slow washing, background. So when I first started in this field, I would see the radiologist literally taking a mouse, the computer mouse, in the image, go in the tumor, circle a little area, and try to eyeball the curve to see if it is or it is not. This was one of the things that pushed me to get into this field. Like, we have like 1 million segmentation methods published out there, right? And these people in the clinic who make decisions about what treatments people should get are doing it with a mouse. That was a shocker to me as a grad student. So that's when I said, this is really what I want to do when I grow up. I'm still growing, by the way. So in this tumor, you can say the pixels at the first time point are the ones that have the fastest washing, right? That's why they light up right away. The ones in the blue ones are the second one, a little slower. The ones in the green, the slowest ones, right? So question, what could be happening in that part of the tumor that's yellow, that has the uptake so quickly versus the part? So I'm trying to connect here what we see with the radiomics and the biology. So what could be happening in the yellow part of the tumor that has this sharp wash-in versus the green part that has the slope? Yes.
Could it be growing more aggressive in that? That's why it has like more blood.
Exactly. So it could be a marker of aggressiveness. Bingo. Next time we'll have like a point system, right? Like a, candy or something, and why is that important? Because, for example, in breast cancer, there are therapies that directly target this process, the angiogenesis. So if the tumor is feeding off the blood flow, cut the blood flow, tumor's going to die, right? That's the basic, not that simple, but, that's the principle. So where we are right now with these radiomic methods and so forth is that we can really visually and quantitatively capture that heterogeneity, both spatially within the tumor, but also we have techniques that we can do that temporally. Like if you have like functional data, like high dimensional dynamic PET scans, for example, we can look at this, there's time curves, and we can find different habitats of the tumor that different function. Where we're kind of a little clueless still is, what does this mean, right? Sometimes if you have like molecular, let's say, data, you can sort of, okay, let's say we have a tracer that is binding to estrogen, a part that binds more of that has more estrogen. That's a good interpretation. But when you have like MRI stuff or you have X-ray data, there's much less you can infer about the biology. And I have yet to see a well-designed study, and it's a study I would love to do, where you do a prospective collection and then you try to register the clinical sort of scan with histopathology and multiplexing and other things, even single cell, to try to do this mapping. Because if we could do this mapping, literally we could have virtual, very cheap assays for tumor heterogeneity. I mean, the scans are all done clinically. Nothing has to be done just for this purpose. They're sitting in the database. Nobody looks at them again, right? A thing like this can run on a workstation in seconds. It doesn't take like 4 days to go to California and come back. And it costs like $100 maybe per case versus $4,000, right? So there's a lot of potential here to develop tools that can be deployed real deal in clinical practice, not just, kind of theoretical evaluations. So we did the similar thing here, right? Where we took features that describe tumors and did unsupervised clustering and came up with phenotypes. And then we try to correlate with the outcomes of the genomic assay. So always an important question to ask when you try to develop a new thing, whatever that is the so what question, okay? Always you got to add something, what's the standard of care? Or if you're going to replace it in a way that's more efficient or cost effective or something. So if the standard of care, for example, in this case is the Oncotype DX, how do we compare to Oncotype DX? Do we say the same thing? If that was the case, great. Let's take the MRI scans and pay $100 and get the same information. If we say the different thing, let's put those pieces together, genotype and phenotype, and see if we can do better predictions. So what was very interesting, and you might not be able to see it very well, I'm going to go there and show you. This two, if you look at these two clusters, this cluster and this cluster, only had low and medium risk tumors by the assay. Those are the tumors that would not benefit for added adjuvant chemotherapy. So interesting, the phenotype just picked out of the blue, we don't know if it will validate if we do it in like thousands of women, but it picked out half of those women, we know that they wouldn't benefit from adjuvant chemotherapy. So even if nothing else, even if we could have good predictive ability for these women, maybe then we could direct the more expensive assay to the other ones. Because there's more and more omics that are coming out, and at some point, we're not going to be able to apply everything to everybody. We have to figure out ways to become efficient in a clinical workflow. And in the other two clusters, there was a mix. So in this phenotype, for example, there was low, medium, and high. All of it here the same. What could that mean? Well, maybe those are the tumors that are more heterogeneous, and there was more of a mismatch, between where the biopsy was done and the imaging looking at the whole thing. Maybe there we can have complementary information. And I'll show you some example of these tumors. So on the left-hand side, there's a tumor that's supposed to be by the molecular profiling assay at low risk of recurrence. On the right-hand side, there's a tumor that's supposed to be at high risk of recurrence. Okay, going back to the first discussion we were having about MRIs and the slopes and stuff like that. As you can see, the low-risk tumor has a mix of pixels, with red ones being like very sharp uptake, time to peak. They get their peak at time point 1, green is time point 2, blue and time point 3. The one on the right is all red. They all get very quick uptake of the tumor. If you were just looking at volumes of the tumors, maybe you would have gotten similar measurements. I mean, the margins are maybe a little more different in the high risk, but really what makes these tumors different is the internal makeup of the tumor. And in the clinic, a lot of time, the measure response to therapy by taking the longest diameter of the tumor as a measurement of response. If you try to find the longest diameter in both of these tumors, first of all, if we'll sit down and we do it, we'll come up with different numbers for sure. But it may be similar, right? If you look at this, from here to here, right? And you look at this from here to here, it could be the same, or very close, right? It doesn't tell you anything different. But if you look at the inside of the tumor, this tells you a lot. That the one that high risk is basically maybe more angiogenic, has all this kind of activity that takes up the contrast agent very quickly. So that could be another sort of biomarker information. And this is another area we've done some work where we look again at this unsupervised clustering approach, at the phenotypes of heterogeneity, and then we follow up women to see their survival outcomes. This is tough for breast cancer because it takes 10 years to collect outcomes. And this was an NIH grant we finally got funded many years ago. I wrote that thing 6 times, it was really, and the main thing every time it would get stuck is, well, by the time it's 10 years, your scanners are going to change, right? Well, we can't get away with that. There's no way that the scanners will stay the same for 10 years. So the premise here is that, if you can see a signal with the older scanners, the scanners only get better in terms of image quality and field strength and stuff. That signal will get better. If your background is in signal processing, there'll be less noisy data. So if it works with the old scans, it'll work with the new scans, even better potentially. But we were able to see that those different phenotypes definitely had different survival profiles, statistically significant, and they could add value to the conventional histopathologic prognosticators. Again, this data is sitting in a database in radiology. Nobody's looking at it. And nobody mines this data to do anything, in this setting clinically useful. And you can see how these scans look different, for a tumor that has low heterogeneity versus medium heterogeneity versus high heterogeneity. You can visualize it. Now you can also quantify it. And we can also see that some of those phenotypes that we detected actually correlate with differentiation of the tumor, which makes sense. The tumors that have higher heterogeneity based on the imaging phenotyping also were more poorly differentiated. And we know that that is indeed the case when we think about tumor heterogeneity. And the same, for example, with mitotic stage, the tumors that had higher heterogeneity had a higher mitotic stage as well. So pieces are starting to come together, like it makes sense. Yes.
Can you measure the genomic heterogeneity using a small bit of the tumor or the entire tumor?
A small, nobody does it in the entire. That's the thing. Clinically, it's never done in the entire, and it's in a small.
So could it just be that the
Yes.
sample is the part that may be more or less efficient?
Absolutely, absolutely. You know, but but it's very hard to do the other study. But it's a study that I would love to do. Like you have to prospectively recruit, to put some markers before the surgery. So when you could try to register with a scan post-surgically for the specimen, you know what is where and try to map it. It can be done, but it's tough. But you know, it needs very careful planning. And I think it would be a very, very nice study to try to get into the biology of these things a little bit. Yeah.
When they come up with like new protocols, like we started with T1 and T2 hyperexpressivity, right? And then now we have fiesta and all of these things. Are these essentially just derived from radiomics? Like, is that where this can head of like you just have like a new phase sequence or imaging protocol where you say, hey, like you're looking at this and you try to do things that can actually signal vascular hyperexpression?
Yeah. You can also try to do some correlations like that, but you can also rely on harmonization of the features to try to adapt to the new protocols as well. You might need to retrain a little bit, but it's doable. And another thing is, so predicting response to therapy. So at baseline, you get diagnosed. We can have all this prognostic information. Based on that, they can make a decision. But then during therapy, we also want to know who's responding, who's not responding. If a patient is not responding, we'd not necessarily want to keep them in the same arm because that, it's not good for the patients. It depletes the immune system. It adds toxicity. If this therapy is not going to work, better put them in something else. So we want to know early in the course of therapy if therapies can work or not. So in this field, there's also a whole big field of what we call image registration techniques that can basically take scans and mathematically, lots of theses written on this topic, like align them as best as possible. And then through this process, you can not only see heterogeneity at baseline, but you can see how this heterogeneity is changing at a voxel by voxel level over time and get longitudinal signatures. And you can also get what we call deformation field measurements. So when you try to do this mapping, this registration process, you can see how the voxel deforms. Does it shrink? Does it expand? Does it stay the same? Which can provide more fine sort of information about the tumor shrinkage or expansion. But again, the inside part of the tumor may be doing stuff before the volume changes. It can start becoming necrotic. And one of the major trials that established the role of imaging in this field is the I-SPY trial, which showed that the tumor volume was predictive of pathologic complete response and survival in women undergoing neoadjuvant chemotherapy for breast cancer. But again, the measurements here were a little bit sort of crude, just tumor volume as a whole. They call it functional tumor volume, which they take the enhancing part of the tumor, segment based on the enhancement, and calculate the volume of the segmented voxels, basically. Which you can multiply the voxels by the pixel depth, and you get the volume of the tumor. And so in this area, we've done a lot of work trying to layer on with radiomic features and see, for example, if we add radiomic features to the tumor volume with and without registration, if we get better prediction of pathologic complete response and survival. And in all of our experiments, we're seeing that when you add registration, you do much better. I mean, first of all, if you add radiomics, even without registration, you do much better than if you just get the tumor volume information. And then if you add registration and techniques that can also make the signal better over time, you can see much more improvement in predicting the outcomes. In fact, our team participated in software challenges of this I-SPY trial where they give you the data set and everybody throws in their algorithms and they run it, and they've done it for I-SPY 1 and the more newer I-SPY 2, and we've done the best in both challenges. So that's something I feel very excited about, because when we were doing the challenge, I had COVID the first time and it had knocked me out really badly and everybody was trying to make the deadline and I was not very good at being responsive, but still, we were able to get through it. So it's exciting work, and we're hoping to work together here to try to validate some of these results in larger populations and independent samples, integrate with molecular profiling data. This trial, I-SPY 2 especially, has publicly available all their profiling. They've released 1,000 scans. They're now in the process of releasing another 2,000 basically sample and a whole bunch of profiling data for those as well. So it's a great database to work on. Yes.
Going the other way in scale, have you combined EHR
Yes.
with the first disease trajectory?
In a very simple way, not in a doing like a phenome-wide association study or anything like that and becoming more sophisticated, but yes. And wait until my last slide. Yes. And so what we saw, for example, here in neoadjuvant is that, once you layer on that information, you can see further stratification that you would just see from the volume, potentially capturing changes of the internal part of the tumor that can be more predictive that a patient is actually responding to the therapy. And similarly, we translated these methods again to lung, doing similar pipelines, segmentation of lung tumors. We've looked at association with response to targeted EGFR inhibitors and to immunotherapy, and looking at how we can combine the lung phenotype from CT scans with liquid biopsy data, and that gives us better predictive ability, which it does potentially because it brings together different pieces of the heterogeneity. And also, again, in immunotherapy, similar approaches looking at the phenotyping, getting better survival curves when we add this information, and so forth. We're engineers also, so we have a lot of fun just building gadgets. That's never going to get out of our blood system, I think. And so, we developed this tool called the Cancer Phenomics Toolkit. It's publicly available. It was funded by the NIH, the NCI ITCR network. You can download it, you can use it, and it's agnostic to the imaging data. Pretty much all the analysis we do right now, at least in my lab, is with this tool. It's standardized, it's compliant with the International Standardization Initiative for Radiomic Features. It has pipelines for segmentation, but basically you can do this type of analysis without having to be a heavy coder in that aspect. As I said, it has different layers of architecture, it has segmentation pipelines, it has radiomic feature extractions, and so forth. And another area that we're really sort of very active in, I would say 40% of what we do in the lab is really to develop image analysis methods. The next to the 60% is to leverage sort of this type of methods to integrate imaging with non-imaging data. And that's an area that I'm very excited to build synergies with your department, which is one of the best departments in the country for doing this type of work of looking at integrating the imaging phenotype with non-imaging data, EHR data, digital pathology, histology, profiling assays. And I think like the times where you just throw everything on something and hope it predicts are starting to be gone. Like we need to be thinking about more sophisticated methods. So how do we bring all this data together in a sophisticated way that can lead with redundancies, but at the same time, find independent information in a way that can be interpretable. We're integrated in a lot of different consortia, national consortia and trials in that way. So for example, the CAPTK is already integrated in the main sort of imaging database platform of the Eastern Oncology Cooperative Group and Akron network. So anybody who's doing a clinical trial can use it without any strings attached and extract this feature as a biomarker. And again, I said, I think as a data scientist and computer scientist and a little bit of, biostatistician, honorary biologist, what I'm really excited about is try to leverage this sort of data science sort of field and AI and however we call it at different points in time in developing sophisticated methods to put all this data together. When a doctor makes a decision clinically, they don't just look in one source of data. They look at the EHR and no comorbidities, family histories, things like that. They look at the radiology report. They look at the result of the oncotype score. They look so much information that gets synthesized in the human neural network to make a decision. And so I think we need to be following a similar paradigm here where we can't just look at one modality. We have to bring all these modalities together in a sophisticated way. And I think it's an exciting future, for people in your field to come together to try to develop the appropriate methodologies, which I don't think we fully have at the moment, but also how to integrate these methodologies into the clinic. So we will be setting up a new center here at Columbia in the medical school that basically will have exactly a focus around this area, housed in the Department of Radiology, but also with strong ties with BME and DBMI and the Cancer Center and the Mailman, and then try exactly to do this thing. And, I'm very excited also, to talk with Dr. El-Haddad about how maybe we can put together even a graduate program or a training program that students who are interested in working in this area can come together through these different departments and help build this sort of, I think Columbia is uniquely positioned to build this expertise, can be a national leader in this area. And that's what got me excited to come here in the first place. So, and the other fun thing about doing this work is really you can't stay in your silo to do this work. It's largely multidisciplinary, so you get exposed to all kinds of people. Like, most of my students and lab members, I urge them to have additional co-mentors, we collaborate with oncologists, epidemiologists, biostatisticians, geneticists, pulmonologists, primary care doctors even, all pathologists, all these areas of expertise need to come together and put these different pieces of the puzzle to kind of develop these approaches. So I'm happy to take any questions if we have some time, but I'm also super excited to be joining you all in January. I'm right now in a tsunami of lab transfer logistics. I hope to survive until January 1st. There's a lot to think about moving a lab and doing all of that and moving a family and kids. It's like a lot going on. So it's been a long time since I felt so busy and overwhelmed, but hopefully we'll calm down. And then when I come here, it's going to be all just fun. No more logistics, right? So thank you. It's a pleasure. Thank you for having me. And I'm happy to take any questions. Yes.
Dr. Kontos, thank you for the talk. I think one thing, so here I'm talking about.
Who are you?
Oh, my name is Young. I am currently supervised by Caroline and Joshi.
Wonderful.
My system multimodality. And I also work in lung cancer.
Wonderful.
Up my alley. One thing I'm very curious about is when I was in national cancer back in Korea, we discussed that breast density, especially for East Asian women, especially Korean women. We tend to have smaller and denser breasts and not worse outcomes. In fact, cancer incidence rates are lower in South Korea than they're in the United States, and the outcomes can be better. Now that can be tied to better screening, better treatment methods, early treatment, etc. I'm just curious to see, and we had difficulty translate our radiomic models to especially American and European patients. And I was just curious about if this precision or even this generalizability argument is an issue that you see as maybe, do you see it an issue of deployment? Do you see it if we're doing deep learning, is it just an issue of just transferring on domain, using domain adaptation or domain generalization methods, or is it something that we can just account for on the data side where we just get more data from more diverse data sets?
I think it's a little bit of everything. First, I think we all need to take the responsibility of when we design these studies to have more diverse data. We all develop our models in a little wheelhouse, whatever that is, and then we expect it to go on the other side of the world and work the same, and it doesn't, and we're all shocked. That's expected, right? So we all need to take responsibility as a scientific community when we do these studies to make sure that we have diverse enough samples to represent the general population. And that's something that's drew me to Columbia personally as well. The other thing is, talking specifically about density, percent density has a denominator too, the dense area versus the whole breast. This is why I'm saying, some of these techniques can help us show us biology. So Korean women may have the same amount of dense tissue, but they have smaller breasts, so the denominator is smaller. You have those differences. There's a lot of thinking right now that maybe it's the fat, because the fat controls the production of estrogen, right? And that could be related to the development of breast cancer. So some of these tools, if they could be a little bit more interpretable, maybe they could shed some light into these questions. But definitely we need more diverse data. Of course, we need things about transfer learning, augmentation, all those things are good, but those alone are not going to solve our problem. We need to definitely be making an effort towards creating the international consortia and the ethnically diverse consortia to be able to do this work. And the frustrating part is that the FDA doesn't really uphold right now those standards very well. So a company can take a tool like that, train it on 1,000 whatever population and put it in the clinic. But then when the doctor uses it, they don't know what it was trained. So they assume it's good for everybody. So that's a little frustrating. And I think that's when we need to take responsibility as a community and say, hey, we can do better. Yes.
Thank you so much for the nice talk. I wonder that you are talking about a very exciting future direction. You will integrate, explore both image data and text data. But so far, I wonder what interesting aspects have you discovered just by exploring image data? Because you do have the power of here, and you can apply those like convolution filters, and you can visualize them. Have you ever identify any interesting patterns that could be potentially correlated with some supervised labels like survival after diagnosis?
Yeah, so for example, one thing that we've seen in others, not just our group, like for example, when we look at tumors and response to immunotherapy, is the area surrounding immediately the tumor plays an important role in the prediction of the outcomes. So you say, why does the area around the tumor? Well, that makes sense because so response to immunotherapy relates to the infiltrating tumor lymphocytes in the tumor, and how does that, the relationship with the microenvironment and the immune system, which that area around the tumor may be representing. Biopsies don't even care about that area, right? Don't even look at that area even. And so I think, there can be several, or for example, when we look at breast density, essentially some of these models may start to point also in the fatty area, not just the dense area as a driver for breast cancer. So there's definitely value, I think, in letting the data show us in a hypothesis generation way, not a hypothesis testing, kind of help us generate hypotheses that then we can test.
This is very exciting to me, by the way, because I feel like human experts are overwhelmed by data. And
exactly.
They may now notice some patterns. Some patterns exist, but humans just do not recognize them.
Exactly.
Because of all of
that. Exactly.
But I do acknowledge that so many of the challenges, like you mentioned, versions of scatters and stuff.
Yeah. Well, that's good to keep us busy, right? We want to be in this business for a long time, right?